everyone, and thank you again for joining us today for our COBRE seminar. My name is Patience Moyo, and I am an assistant professor of health services policy and practice at the Brown University School of Public Health. I have the great pleasure this morning of introducing our speaker, Dr. Haiden Huskamp. Dr. Huskamp is a health economist by training and the Henry J. Kaiser Professor of Healthcare Policy at Harvard Medical School. She has three primary areas of research, one being mental health and substance use disorder policy, another is prescription drug policy, and the other being the financing of and utilization of end-of-life care services. Dr. Huskamp also serves as director of Harvard's National Institute of Mental Health pre- and postdoctoral training program in mental health policy at Harvard University. Today, she will talk about her work on telemedicine and the treatment of mental health and substance use disorders. I'm sure many of you will agree with me that this is an important and timely topic, important in the sense that we know that there is undertreatment of behavioral health conditions and that telehealth technology has the potential to improve treatment access for behavioral health conditions. This topic is timely also because in light of the COVID-19 pandemic, there is a move to deliver certain types of care virtually. And so there is evolution in telemedicine. And so we're excited today to learn more about telehealth and behavioral health treatment in particular, both before and after COVID-19. And with that, I would like to welcome Dr. Haiden Huskamp. And before I let her take the stage, I would like to point out that she has agreed to take clarifying questions during the talk, but we will have time at the end for discussion and to take further questions. But if you have a quick clarifying question, let me know through the chat box that you have a clarifying question, and I will find a point to call on you to ask that. But thank you all and welcome, Dr. Huskamp.
Well, thank you so much, Patience. I'm just gonna take 1 second to pull up my slides. Excuse me a second. Let's see. Can everyone see the slides? Are they okay, Patience?
Yes, we can see your notes too, though. I'm not sure.
See, I don't want to do that. What did I do? Let's see. Try this. You still see the notes?
No, we don't.
Okay.
Slides, you can make them full screen and then they'll be good.
Of course, we tested this out in advance and let's see, does that?
Yes.
Perfect. Okay. Thank you. Sorry about that.
No problem. Thank you.
Thank you all so much. I'm really, I was really looking forward to being here today. I'm sorry I can't be in person. That was the hope when we set this up, but really glad that we're still able to do it virtually. So today I want to, as Patience said, I wanted to talk a little bit about some work that I've been doing looking at telemedicine and how it's being used for substance use disorder treatment. I feel like these days I tend to think about time in a different way than I did a year ago. And now I often find myself thinking about time before COVID and time after COVID, given how different the world looks. And I think the talk today is going to do a little bit of that. That I first want to review some findings from some work that we did a little less than 2 years ago to try to initially understand how telemedicine was being used for substance use disorder treatment in a commercially insured population. But then contrast that with some very early work that we've been doing post-COVID to try to understand how it's being used now. So a little bit of pre and post. Here are so a couple of quick acknowledgements. First, I want to acknowledge my co-authors on these two pieces of work. There are many folks who've been involved and played an important role, and I want to highlight Dr. Ativ Mehrotra, who's my co-PI on the grant that funds a lot of this analysis. And also mention certainly that we're very grateful to NIDA for funding the work, both through an R01 and also through the Brandeis Harvard NIDA Center to Improve System Performance of Substance Use Disorder Treatment. It's a long name, but it's a P30 mechanism. So, everyone on this video seminar today certainly knows that a large proportion of people with a diagnosable substance use disorder don't receive treatment, something along the order of 1 in 5 typically in a given year. And there are many factors that lead to this treatment gap, but an important one is the shortage of SUD providers in many areas, especially rural areas. And telemedicine, involving remote diagnosis and/or treatment via, typically via live video conferencing. I think that's how we were certainly thinking about it for the most part pre-COVID, is an option that's been discussed quite a bit over the last few years. In the treatment of mental illness, telemedicine's use had been growing pretty dramatically pre-COVID and was used fairly commonly. And its efficacy had been shown in multiple trials to be comparable or even superior to in-person care. And while telemedicine's efficacy was not as well documented back then for SUD, more evidence was coming forward, and there were groups, including the President's Commission on Combating Drug Addiction and the Opioid Crisis, and groups like the American Society of Addiction Medicine and many others, who'd been advocating for telemedicine as a way to expand access to SUD treatment, especially for certain subgroups of patients. So patients in areas with few providers, for example, in rural areas, patients with transportation barriers or physical barriers or privacy concerns. So it was being seen as a way to expand access back then. However, there are a number of regulatory and reimbursement issues that served as barriers to the expansion of telemedicine. An important one for the treatment of opioid use disorder was the Haight Act of 2008. And this act was passed back then, over a decade ago, in response to a young man who received an opioid prescription online and died from an overdose. And so the law put in a number of restrictions around the prescribing of controlled substances via telemedicine. Certainly it was regulating online prescribing, but it affected the prescribing via telemedicine as well. And so although it was targeted at opioids, traditional opioids, it affected drugs like buprenorphine, which are also controlled substances. And it generally requires that a physician examine someone in person before prescribing a controlled substance. So this was an important barrier. There were a number of other barriers as well. Certainly on the reimbursement side, Medicare had only covered telemedicine back in, up until sort of mid-2019, had only covered telemedicine when it was provided in rural areas, and patients couldn't receive it in their home. They had to go to and be hosted in a local facility in order for the telemedicine to be reimbursed. The Support Act of 2018 removed some of those Medicare requirements. Well, it addressed a couple of these barriers. It certainly removed the Medicare requirements for coverage of telemedicine for the treatment of substance use disorder and co-occurring mental health conditions. So at least for this subset of conditions, just for SUD basically, Medicare would now cover telemedicine that was provided outside of rural areas and could be delivered in the home. And it also promised to provide a pathway around the Haight requirement of an in-person visit for the prescribing of controlled substances like buprenorphine. So that hadn't yet been implemented pre-COVID, and it wasn't clear exactly what it was going to look like, but that was part of the Support Act. So some of these barriers were reduced through support. Back in December 2018, we published a study in Health Affairs using data from Optum Labs, which includes claims data from one of the largest commercial insurers in the country. And we looked between 2010 and 2017 at utilization. Excuse me. We found that the number of Tele-SUD visits used by enrollees who were diagnosed with substance use disorder, and by that we mean either the primary or secondary diagnosis was SUD. That rate increased quickly over the period from 0.62 visits per 1,000 people diagnosed with SUD to 3.05 televisits per 1,000 people diagnosed with SUD in 2017. So it was increasing pretty rapidly. But if you look at the line above, the red line, this shows you the use of telemental health visits. So again, where the primary or secondary diagnosis is mental illness. And here you see that visits increased in 2010 from 0.91 per thousand to about 16 and a half visits per thousand. So on the mental health side, it was used more commonly and its use was increasing faster than it was on the substance use disorder side. And at the time, we saw this as a missed opportunity for Tele-SUD in the context of the opioid crisis that's been ongoing. We also found back over that 8-year period that Tele-SUD visits accounted for just over 1% of all telemedicine visits that were reimbursed by the insurer in those years. But telemental health was used much more commonly, again, accounted for over a third of all telemedicine visits. It was the largest category of care for which telemedicine was used, and much larger than SUD. About 15% of the Tele-SUD visits were for psychotherapy. I think that was a little surprising to us. We expected to see a little bit higher rate there. About 33% of the televisits for SUD were for established patient visits, and about 42% were for initial evaluations of new patients. Here are the folks who were using it compared to the folks who weren't. So among those who used it, so all of these individuals had a diagnosis of substance use disorder. And then we looked at those who used Tele-SUD and those who did not. Among those who used it, most were men, about 55%, and just over half, also about 54%, were under the age of 40. Tele-SUD users were more likely to have a diagnosis of a moderate or severe substance use disorder than individuals with SUD who didn't use telemedicine. That was about 88% versus 39%, so much more common. Tele-SUD users were also more likely to have an OUD diagnosis than individuals with SUD who didn't use tele. And they were also more likely to have a diagnosis of severe mental illness. That was about 56% versus 20% of non-Tele-SUD users. So it looked like folks who were using Tele-SUD had sort of more complicated clinical situations, were a little bit more likely to be diagnosed with a severe or a relatively more severe condition. We also looked at utilization, and the median number of Tele-SUD visits among people who got at least one was 1, and with a mean of 1.6. And then you see the first panel shows you all individuals with any substance use disorder. The right panel is showing you those specifically with opioid use disorder. And the numbers are pretty similar, as you'll see. Almost all Tele-SUD users, 99% or more, had at least one in-person SUD visit in that year as well. So although I think some people had envisioned telemedicine being used exclusively for patients with SUD, that there would be a subset of patients who would only get tele, we weren't seeing that at this time. Anyway, almost everyone was using a combination of, who was using tele, was using a combination of in-person and tele. And they were disproportionately using the in-person care, as you see in the slide. The median number of in-person SUD ambulatory visits for tele users was 10, compared with 4 for non-tele users. We also found that tele users were more likely to be using medications for SUD during the year. So we looked at medications we looked at were the OUD and AUD medications, alcohol use disorder medications. And almost 2/3 of Tele-SUD users used SUD inpatient care versus just 1/4 of non-tele users. And the tele users also used SUD intermediate care at higher rates. So it definitely, this sort of supported the findings from the previous slide. The folks who were using tele seemed to potentially have, certainly be using more care, a lot more in-person and intermediate and inpatient care than and medications than individuals who weren't using tele. And as I said, the patterns were similar on the OUD side. The other thing we looked at was sort of who was delivering these televisits back pre-COVID. And a variety of clinician types. If you look at the far left bar graph, you see that there were a variety of clinician types delivering Tele-SUD before the pandemic, with 29% of visits delivered by psychiatrists. But almost half, 46%, were delivered by family practice or internal medicine physicians, and just 1% by psychologists and 12% by social workers. The middle bar shows you non-telemedicine, sort of the in-person SUD ambulatory visits. And the numbers look a little different here, with a smaller share provided by psychiatrists and primary care physicians than you saw on the tele side. And then as a contrast, we also showed what was happening on the far right with telemental health visits, who was delivering those. And almost half of those visits were delivered by psychiatrists, so much larger share. So primary care physicians seem to play the largest role for tele-SUD relative to these other types of services back over the period 2010 to 2017. But then, very quickly, if we sort of fast forward to where we are today, the world basically sort of changed overnight, it seems, or it felt like. And starting at the beginning of March, the pandemic began to take hold. And as of March 17th, 2020, the Centers for Medicare and Medicaid Services announced that they were expanding telehealth coverage due to the pandemic. So as you'll see in some of the work I show you later, we sort of use this as a marker for when the pandemic really took hold, such that CMS changed these policies. Additional regulatory barriers were removed that support hadn't removed. So for example, some important ones were around HIPAA and privacy rules. Now providers were allowed to deliver telemedicine via pretty much any application you can think of. In talking with clinicians, some people are using FaceTime, Zoom, all kinds of platforms that some of which previously weren't allowed because of HIPAA concerns. So a number of barriers were removed. Also, the rules around the Ryan Haight piece of that, the sort of prescribing, were loosened, allowing physicians to prescribe without seeing someone in person for OUD. As I'll show you some data in a second, in-person visits really plummeted, and many clinicians began using telemedicine for the first time. So it really was sort of like a switch went off, and a pretty small proportion of clinicians had been using it before, and then things really changed dramatically in March. Here are the data that I was just referring to. This slide features data from a study done by my colleague Ativ Mehrotra. He used data from Phreesia, which is a technology company that helps ambulatory practices with different administrative tasks. So things like patient intake and payment and registration. And so these data come from about 1,600 provider organizations across the country, ranging from solo practices to federally qualified health centers to large health systems. And represents about 50,000 providers. And this analysis found that the volume of outpatient visits as a whole across all specialties, so this isn't just behavioral health, dropped by almost 60% in March and April, before rebounding quite a bit over the course of the summer. That initial rebound was driven, at least in part, by the rise in use of telemedicine, which replaced a fair amount of in-person outpatient visits that had been happening in the past. And you can see it, according to this again is telemedicine across all types of care, not just behavioral health. It seems to have really peaked around 15% of all care in March and April. It's important though, when you look at the data from that last slide and you see that proportion that were delivered via telemedicine, to realize how different the provision of telemedicine was across specialties. So some of the specialties you see here, like ophthalmology and orthopedics, a very small proportion of the visits that were delivered as of the week starting October 4th of this year. So this is pretty recent data here. a very small proportion were being delivered via telemedicine by that point. But behavioral health still in October, over 40% of visits were still being done via telemedicine. So there's a lot of variation across specialties in its use during the pandemic. And some of this may be because due to the fact that before COVID, the most common use of telemedicine was for behavioral health clinicians. So more folks were used to it than for some of these other specialties. And also some people would argue that behavioral health may be particularly well suited to telemedicine, at least relative to other specialties, because of the nature of the treatment and sort of how the care is delivered. That team also showed the change in outpatient visits experienced during the early months of the pandemic really varied by specialty. So for example, if you look at behavioral health, which is on my slide, it's sort of an aqua color, it never really took the big nosedive relative to the baseline number of visits that were delivered that some of the other specialties took. If you look at dermatology, just, over a 70% drop in visits from baseline in March and April. It also didn't rebound as much as some of those specialties. So you see dermatology actually by the end, sort of midsummer, seems to be delivering even more visits than they did at baseline, which is kind of interesting. Whereas behavioral health is still delivering below the baseline at that point. But certainly it didn't take as big of a hit, probably for some of the reasons that I just mentioned. So as after the pandemic kicked in, our team knew it was going to be quite some time before, due to data lags, before we would get any claims data to be able to try to understand how telemedicine was being used and how care was being delivered as a whole during the pandemic. So we decided to start with some qualitative work. And Lori Usher-Pines from RAND, who's a member of our team, led a recent qualitative analysis where she interviewed 18 OUD clinicians that were last spring in hotspot states where the pandemic, so certainly my community was, we had folks from Massachusetts represented in those interviews because we were a hotspot state. So, and you guys as well. In these interviews, we asked these OUD clinicians who had waivers to prescribe buprenorphine about their experiences thus far. So these were conducted in April. How things were going. Did they have concerns? What were those concerns and that sort of thing? Sort of how was the care that they were delivering different, if at all, from before the pandemic? And their reactions were mixed. So we heard a fair amount of positives. We've heard that many of the clinicians told us that they felt that the transition was much easier than they expected, that it was going much better than they expected. Because most of them hadn't used telemedicine before or had used it very small amount. They said that their patients were very grateful to have some way to access care during the period where they were not comfortable going in person. So they also noted, we heard pretty much universally that their no-show rates really dropped. Now, I don't think you can attribute all this to the ease of telemedicine because certainly people didn't have as much going on during the pandemic. They were mostly home and that probably made it easier for them to participate in visits. But we heard that, and certainly many of them expressed to us that they felt that this increased access for their patients and certainly increased convenience for their patients, and that they felt that many of their patients would want to keep doing this if given the chance. But there were certainly some negatives that came up in these interviews. We heard, and by the way, the site is at the bottom of the page if you're interested in reading more about this. Some negatives we heard is that some told us that they felt that telemedicine visits didn't provide the same sense of accountability for their patients as in-person care. Some of them told us that, some of them were having to do some of these visits via audio, via telephone only. So it's certainly impossible to observe physical symptoms of withdrawal that way. But even via the video screening, they said that it was harder to observe certain physical symptoms. You only see typically the neck up And it's not always, screens aren't always clear. And for a variety of reasons, it was harder for them to sort of really observe everything they would normally want to observe about the patients. And they also felt that sometimes it was more challenging to assess whether the patient might be lying about their drug use or, really sort of assess what was going on. Some told us that it was harder to establish rapport with their patients, especially their newer patients, via video or in some cases phone. And as I just alluded to, not all the patients could use video technology. There was a real issue that we heard about very early on about the digital divide, where for a subset of their patients, either the clinician reported that the patients did not have internet that was sufficient, did not have a device that allowed them to use video technology, weren't comfortable, didn't know how to use it, needed a lot of help. For a variety of reasons, this was a challenge for a lot of folks. They also noted some changes that they'd made to their treatment patterns for their OUD patients during the pandemic. So we heard that a number of them reported that they were waiving urine tox screening or requiring it less often than they normally did. Some told us that under normal situations, they would require their patients to have more visits with them, more regular visits, maybe every week, every 2 weeks, whatever, during certain phases of the illness. But they were doing that less often. And some told us they were giving patients a greater supply of medications at one time than they normally would. And a number of them told us that they were hesitant to take new patients or to do inductions during the pandemic when they were relying on video or audio technology. So this qualitative work led us to sort of prioritize a couple of questions that we really wanted to focus on when we got our hands on some claims data. And here are, what sort of came to mind for us. How has the pandemic affected access to OUD care, particularly outpatient care? How has medication use been affected? How is urine testing being handled during the pandemic? And any changes in care patterns for OUD that we saw, how did things compare for established patients with OUD versus brand new patients with OUD? So this is where we started once we got access to some data. And I wanted to mention the results that I'm going to show you now are sort of like, they're kind of brand new for us. They're in the review process. And so we'd appreciate it if you would not, share them or circulate them in any way. So thank you for that. So we again turned to the Optum Labs data so we could study these issues among commercially insured individuals and Medicare Advantage enrollees who were between the ages of 18 and 64. And our approach was to create a cohort of folks who were continuously enrolled from January through May of 2020, the sort of COVID year, and then compare their utilization of OUD care to individuals who were continuously enrolled for January through May of 2019. So basically using the 2019 experience as a comparison to the 2020 pandemic experience to see if utilization patterns look similar or different once the pandemic kicked in, starting in March. We also divided people into two groups. In each of those year cohorts, we divided people into two groups. Oops, I'm sorry. The first group were people who were currently or recently taking OUD medications. And we identified or defined those as people who had a fill for an OUD medication, buprenorphine, naltrexone, or methadone, in either January or February of the year in question. So for the 2020 COVID cohort, they had a fill for one of these drugs in January or February 2020. For the 2019 comparison cohort, they had a fill for one of these drugs in January or February of 2019. And then the other group is obviously those who didn't have a recent fill for an OUD medication. And we did this as a way to try to distinguish people who were had some engagement in care, were getting engagement might be too strong a word, but had some, they were in the treatment system right before the pandemic kicked in versus those who were not taking medications and such an, obviously such an important treatment for this condition, for this illness. We focused on 3 outcomes. So basically each week from the first week of March through the end of May, so it was a total of 13 weeks, we looked at the percentage of people in each of the groups I just mentioned who got at least one of three types of care, who got at least one OUD medication prescription, or in the case of drugs, for example, that are injectable or others, we use a facility or clinician administration of an OUD medication. So we used relevant HCPCS and CPT codes to identify those that were administered by a clinician. But so basically we looked to see the percentage of people who had at least one, what I'll call here from here on a fill, even though some of those aren't technically fills. We looked at the percentage of people who had at least one OUD-related outpatient visit. So these were sort of face-to-face outpatient. By face-to-face, I mean virtual as well, but sort of a synchronous visit, not a lab test only, but an actual visit with the clinician, where the OUD was the primary or secondary diagnosis on the claim. And then the percentage of people who had at least one urine OUD toxicology test, again, where on these lab claims, we required that OUD be the primary or secondary diagnosis. Here are the folks in the two different cohorts, the 2019 cohort and the 2020. And you can see we separated people into those two groups, the people recently with an OUD medication fill, and the people not recently. So in 2019, there were about 16,128 people with a recent OUD medication fill. And obviously the vast majority of people in an continuously enrolled, commercially insured population haven't recently been taking OUD medication. So that's why that number, about 6.1 million is so much higher. And then you can see similar numbers in 2020. And here are some basic demographics. You see the sort of regional distribution for this health plan represented here by the regional numbers. It's pretty even split, almost a 50-50 split of men and women in each of these groups. The mean age is around 40 in each of them. And it's a pretty small percentage of folks in this 18 to 64-year-old population, not surprisingly, who are Medicare Advantage enrollees at the bottom. But the 2019 and the 2020 groups look pretty similar as a whole. Among the people who had recently filled an OUD medication prescription, you see that about 3/4 of them had filled that prescription for buprenorphine. The share taking methadone was pretty small, not surprising, again, for a commercially insured population. And about 1 in 5 took naltrexone in that period just before, in the January-February period for each year. So now I want to show you our first outcome, which is the percentage of people each week who filled an OUD medication prescription. So let me break down these figures, which are a little complicated and busy. So if you look first at the left panel, this is the group of people who had a recent OUD medication fill in January or February of the year in question. The numbers at the bottom are for the week starting the week of March 1st. So they go March 1st through the end of May. It's a total of 13 weeks. The black vertical line marks the week that includes March 17th, which is when, as I mentioned earlier, Medicare announced expanded telemedicine coverage due to the pandemic, and the pandemic really began kicking in a lot of communities. Then you can see in orange on the left, this is the percentage of people who filled an OUD medication prescription each week in 2020, and you compare that to the percentage of people in blue who filled one each week in 2019 over those same weeks. And you can see there isn't a lot of difference here. These lines are pretty close together. In contrast, things look a little different on the right. So these are the people who weren't recently filling an OUD medication prescription. And then this shows you the percentage of those folks who did fill one each week during those same 13 weeks. And again, the orange is the COVID period and the blue is 2019. And so these are basically new starts on medication, people who weren't recently taking it, but did fill for the first time in March through May. And the rates look pretty similar in very early March, right? Their lines are right on top of each other, but then you do see the lines separate once the pandemic kicks in, and you see a lower percentage of people filling new scripts in 2020 relative to 2019. This picture shows you the same graphs, but this time for OUD-related visits. So again, the left panel is people who with a recent OUD medication fill, and you can see the percentage of people each week who got an OUD-related visit, whether that was in person or telemedicine, either one. The lines are pretty much on top of each other for the most part for 2020 and 2019. There's not much going on there in terms of a difference. But there is a separation amongst the people who weren't recently taking an OUD medication. And again, for 2020, the orange line, that percentage is lower than what you saw for over the same weeks in 2019. And then here's the same data, but for the percentage of people who got a urine test each week. And for both groups, in this case, you see a pretty a notable difference with 2020 rates being lower than 2019 for urine tests. This picture shows you the cumulative number and percentage of people getting each of these three types of care over the 13 weeks as a whole. So for example, the first row is the percentage of people who got at least one OUD medication fill over the 13 weeks, which is about 2/3 of people in both 2020 and 2019. So again, the left panel is people recently filling a prescription in January or February of the year. What percentage of them went on to fill another one March through May, at least one. And so for OUD medication fills, actually the percentage of fills in March through May is even a little bit higher in 2020 than it was in 2019. For OUD-related visits, there's no statistically significant difference between 2020 and 2019 for the people who'd recently been taking a medication. And for urine toxicology tests, though, you do see that 2020 rates were lower for this group than what you saw in 2019. The right panel now that I'll show you is, again, the people who weren't recently filling an OUD medication prescription. And you can see that for all three types of care, the 2020 rates were lower for this group than what you saw in 2019. Then in terms of what was the role that telemedicine was playing in the OUD-related visits that I just showed you, this shows you, this is depicting the group of folks who had a recent OUD medication fill in January and February. And then of those folks, if you looked at all the visits, the OUD-related visits that were provided week to week, what percentage of them were delivered via telemedicine? So back in the very beginning of March, before the pandemic really kicked in, those rates were quite low. It was 0.5% in week one, for example, of all OUD visits were delivered via telemedicine. And then it gets up to about a high of 29% of all OUD visits via telemedicine in week 8, and down to about 23-24% in week 13. I'm not going to bother to show you the same graph for the people not recently filling an OUD medication, but it looks very similar. The percentage of telemedicine visits actually got even higher to about 1/3 at its peak, or by the end of the period, week 13, about 1/3 of all OUD visits for that group were delivered via telemedicine. Some limitations that I wanted to mention of what we did. The study population only included those 18 to 64 who had private insurance or Medicare Advantage from a single insurer. So our results may not be generalizable. Although we did study, this is one of the largest health insurers in the country that we looked at, but certainly something important to remember. Our study period only went through May 2020 because of data lags. And I'll mention, in case folks are interested, it was very interesting to see there was a particularly long lag in getting the claims in March and April for telemedicine visits. I think probably no doubt due to confusion amongst providers and maybe plans around rules for reimbursement. But it took a particularly long time to get those visits to show up in the claims data. And then it got resolved and it picked up again. But claims lag were the reason why we stopped looking at the end of May. And we're unable, of course, to observe telemedicine visits or in-person visits that aren't submitted for reimbursement by the insurance plan. One other thing I'd mention, we certainly were concerned too that because during the pandemic, we know many people have lost their jobs and may have lost health insurance along with it. we wanted to make sure that these decreases that we saw in some cases weren't a result of the fact that people were just losing their insurance. So we compared the rates of people who were enrolled in January and February of each year, who then remained enrolled through May. And 92.8% of people enrolled in January and February remained enrolled through May in 2020. The comparable rate in 2019 was 93.4%. So just about 0.5% difference. So although individuals may have lost jobs and insurance, we didn't see differential plan enrollment during our study period. So that isn't what's driving what we see. So just some conclusions, and then I hope we can open it up. During the first 3 months of the pandemic, we found no decrease in OUD medication fills or OUD visits, outpatient visits, among those recently taking medications. But we did see that fewer people initiated OUD medication in the post-COVID period, at least the first 3 months post-COVID. And there was less urine testing across all patients. And we found that although telemedicine obviously played a very important role in maintaining access for the folks, certainly those folks who had recently been taking medication and were able to continue seeing clinicians, it was still a minority of the visits. And so an interesting finding there. You know, obviously going through May is just the very beginning of what we need to look at. And so we're now continuing our work, looking at later periods of time to understand how SUD care patterns have been affected as the pandemic has continued, and to better understand who was left out, who dropped out of treatment or wasn't getting treatment, how telemedicine has been incorporated into the care model specifically during the pandemic, and which providers are using it now and how. We also are now fielding a survey of OUD clinicians and their experiences and views on telemedicine today, and what they think its role should be in the future. So I hope to have some results on that at some point soon. So I want to stop and see what discussion all of you may have on this issue. Thank you.
Oh, thank you very much. That was really interesting. The seminar is open for discussion and questions. Right now, I have one question that came through from Brandon. And so Brandon, if you can unmute yourself and go ahead with your question, please.
Oh, thank you so much. Thank you so much for a wonderful presentation. It's really interesting to see the results, particularly quickly turning around within less than 12 months. I just had one, I guess, clarifying question about the data set that you used in terms of requiring continuous enrollment. Was there an option to have not continuous enrollment? I just wonder if that would be informative in terms of people stopping treatment if we know that that's not an uncommon practice. So whether having telehealth means people would remain engaged for a longer period than previously.
Oh, so you mean the continuous enrollment? So we can certainly, there's in the Optum Labs data, if anyone ever is interested in accessing it, there's a monthly indicator that tells you, so you can see each month whether someone is enrolled for all 3 types of benefits. So you can check for pharmacy benefits, behavioral health benefits, and medical benefits. And so because we wanted to look at all of those types of care, we really wanted to focus on a continuously enrolled population for those 5 months, which was quite high. It was, 93% basically. So over that period of the folks who were enrolled in January, February, the vast majority are still enrolled. But you certainly could go back and look. We haven't done that yet. But you certainly could go back and look at that small proportion of people who did drop out and see, can you tell anything about their characteristics and how they may be different? I think that may be where you were going. Is that right, Brendan?
Yeah, it was kind of a question of like the nuance in terms of people dropping out. Maybe they have like a longer time period before they dropped out.
Right, you could certainly do that with these data, and that would be something we should do. We should take a look at in the future, but we haven't done that.
Okay, thank you.
Well, thank you. And Samantha, you can go ahead with your question or comment.
Yes, hi, thank you. This was a great presentation. I wanted to follow up on some of the early qualitative findings that you reported from the providers, specifically the difference between phone versus video visits. and whether they feel that a phone-only interaction without any of that visual cues of how the patient is doing, if they feel that it degrades the quality too much when treating these type of conditions. I'm curious what seems to be the current feedback from providers.
Sure, and that is something we're asking about in our survey now. So I hope to get even more information from a bigger group than what we were able to do with those interviews. But we heard that for that subset of patients for whom they had to use phones, certainly the clinicians found it far less optimal. You miss out on so much. There's not that much you can do. They found, it was at least a way to keep in contact with their patients, so better than nothing. But definitely not in any way to their level of standard of quality. We also heard that many of them reported that when they had to use phone only, the visits tended to be much, much shorter because it was just sort of more awkward, and you couldn't really get into the same kinds of depth or issues that you might if someone's either looking you in the eye on a screen or in person. So it was kind of a different type of interaction for sure, and not as satisfying, but I think they felt it was better than nothing.
Yeah, I think that's consistent with some of the work that we've been conducting at the VA, and hearing from some patients that they may specifically ask for a phone appointment on days that they're doing worse because they feel it would be harder for their provider to notice. So I think there are some concerning implications of phone-only care for certain patients.
Oh, that's interesting. I hadn't really thought about the fact of, I was sort of thinking of it as an all or nothing for most patients. You either give them audio only because they can't do video, but you're certainly right that if they're allowed to opt on an individual basis for each visit, that could lead to some interesting choices. And yeah, that's interesting.
Great, thank you.
Thanks.
Awesome, really interesting questions. And Brandon, you can go ahead and ask your question now. Oh, I'm sorry, Brandon, I can't hear you.
Okay, hey, now, sorry about that. Can you hear me now?
Yeah.
I have actually two mute buttons in my computer. I have to hit them both. No, I was curious, as the telemedicine regs were relaxed with the onset of COVID, so were the regulations about how much take-home medicine can be prescribed. And I don't know, I was wondering if you knew if there's any data or anything we can say about the relationship between telemedicine and the length of the dose, right? Because it went up at the start of COVID to up to 28 days. And it seems like providers might be concerned about giving that much medicine to someone they're hardly in touch with or basically on the phone with. And it's just interesting that those two things were deregulated at the same time.
Right, and so far we've only been able to take a quick look at that. But we found with that quick look that even though the providers reported to us that they were trying to give people more medication in the qualitative interviews, we didn't see it in the claims data for this insurer. Now, I don't know if that's because the insurer's policy wouldn't allow it necessarily. We couldn't find any evidence on that, but it was flat. Like there was no real change in days supply, that sort of thing that we saw in this same period of time through May that we looked at.
Thank you. No, it'll be interesting to see if extended take-home doses influence retention. Hopefully they would, but I guess we just don't know because they haven't really been prescribing more from what you can tell.
Yeah, I think that I would hope, I definitely want to keep looking at that going forward and seeing if we see any change or looking in other payers' data because, as I said, it could be unique to this insurer. And if we look in Medicare, maybe we'll see a very different pattern, but it's a really important question.
Great, thank you.
Awesome. Are there any more questions from individuals? You can type and let me know and I'll give you a chance to speak. But in the meantime, I have a question myself, just seeing the data that you presented and some of the findings from the qualitative work in terms of some providers who mentioned that they were not taking new patients. I'm wondering if you can talk about, the care for new patients during this time, where I feel like they might have a harder time getting connected compared to more established patients who might be more likely to be continued on their medication by providers they already know. So I'm just curious if you can speak to what the implications are for kind of helping get more people connected to treatment if they're interested, and new patients.
I think that's a great question. And it, really the findings to me, as I see these early findings, it really does seem a sort of good news, bad news story, because there's a lot of good news here, and that patients who were sort of already kind of, in a sense, recently in the system getting care, they did okay. This didn't really affect, didn't cause a big change in their access or their utilization. But you really worry about those folks who may not have been able to get in, especially during the period that we're in, where we were beginning to see evidence of increases in overdose and opioid use, and the stress and the isolation. And so you have to worry a lot about, the rates I showed you showed that 2020 rates are lower for new medication starts than 2019 folks, but we may even be at a higher baseline level of illness. And so it could be even more serious. And so, it was interesting in talking to the clinicians. We just spoke to another one just the other day when we were pilot testing our survey. And, she said, I'm really particular about the new patients I take now. I would only take patients from certain referring sources because I feel like it is very risky for me to take on a new patient right now. And while you can totally understand that, and they're worried about being able to deliver good quality care, what do patients do? And so, I think certainly in our community, it's much less likely that care will stop, that places will shut down, it seems anyway. I'm not sure that all of the same facilities and providers that stopped providing any inpatient care will continue. That'll happen this fall and winter, we'll have to see. But I'm hoping that places that weren't available last spring in some states and certain hotspot areas will remain open for patients, with appropriate safeguards to allow patients to continue, to get care as needed. It's a really important issue.
Thank you.
All right. Hi, my name is Alvin Shankatay, Director of Project Management at Kodak. Over at Kodak, we treat patients with substance use disorder, and we're at the point where we're trying to get ready to integrate more telehealth and telemedicine. But one problem that we're facing, and maybe a challenge, is where to go to look for policy and to be able to establish policy around how we're able to leverage telehealth and telemedicine to be able to treat our patients. So yeah, I just wanted to ask you, how did you guys go about establishing policy or searching for policy that protected you as an organization and also protected your patients and their information and how that is accessed?
Well, so I should be clear, I am not a clinician. I am a health policy, health economist researcher, so I don't, sort of represent a clinic or set of patients. So I may be less helpful on this question. I know certainly there's a number of organizations out there that are trying to put forward information. A lot of professional organizations, SAMHSA and others, and other folks maybe on the call who are clinicians. I don't know if anyone else could chime in with helpful, with their experiences. That would be really helpful.
Okay, well, we're down to the last minute here, and I guess as a last question from me is, do you think that the relaxation of some of the regulatory and reimbursement policies by Medicare, for example, and potentially other insurers will stay beyond this acute phase of COVID-19? So I'm just curious if you have any thoughts in terms of maybe reverting back to the stricter regulation of telemedicine use at some point.
Well, I think there's, in terms of, if we start with the reimbursement side, I think it's probably going to be a mixed bag. So we've already seen, for example, the commercial insurer that I talked about today, they have already begun to change. They were having, requiring the same, no cost sharing for visits during the pandemic, for telemedicine visits during the pandemic period. They've begun to, they've changed that now, sort of tighten that back up again. But I know that my insurance company, Blue Cross Blue Shield of Massachusetts, has said that they're going to continue to cover at parity telemedicine and in-person care. So I think it may vary by insurer, and certainly what Medicare decides to do is really the important thing, because so many payers will follow suit. And I don't have a sense yet of when Medicare may change their reimbursement policy from what they're doing today, or how. I hope that there will, I don't think anybody wants to be in a situation where telemedicine is the only modality, but I think, we hear from a lot of providers that they'd like to be able to use it as part of their toolkit for either some patients, maybe not all patients, and maybe not all visits, but maybe periodically. And so use it in certain ways. So I hope that reimbursement will be there to allow, appropriate use of the technology. But also on the regulatory side, we will hopefully support will still figure out, we'll still come up with a way to address the prescribing issue that I talked about, the Haight related issue. I will be very curious to see what happens on the HIPAA side of things in terms of which, do they allow this more relaxed interpretation of which platforms can be used to access patients, because that is certainly clinicians tell us it was being able to use those easy to access platforms was very important, both for their patients to be able to use the technology and for them to be able to use it. So that'll be something we'll just have to watch and see.
Awesome. Well, thank you so much. I've learned a lot during this session, and I'm sure others did as well. So thank you, Dr. Huskamp, for taking time to join us today. We're looking forward to seeing your work getting published soon, and we'll keep an eye out for it.
Oh, thank you so much. Yeah, thank you so much for having me. I hope everybody has a great day.